So have you ever wondered what actually happens when your body's ultimate internal processing plant just completely runs out of room? I mean, think of your liver like this massive, bustling factory. It's constantly filtering, producing, and managing your energy. But what happens when the deliveries just keep coming, the warehouse is totally full, and the factory floor gets, well, cluttered with excess baggage?
Welcome to The Explainer. I'm so thrilled you're here today because we're diving into a really fascinating medical investigation. We're looking at a condition that affects up to a quarter of the global population. To put that in perspective, that is a massive number of people, yet it's often entirely silent. Today, we're breaking down the clinical foundations of metabolic fatty liver disease based on our source material. We're going to uncover the hidden drivers, see exactly how it's detected, and most importantly, talk about what can actually be done to fix it.
Okay, let's dive right into this with a clear roadmap. We've got 5 stops today: the overwhelmed liver, drivers of fat accumulation, medical and genetic risks, detecting the silent condition, and finally, the path to reversal. Right, starting off with Section 1, the overwhelmed liver. By definition, fatty liver develops when the liver begins storing way more fat than it can actually process. Going back to that factory analogy, we aren't just talking about a liver that's a little sluggish. We're looking at a scenario where the sheer volume of fat being made and delivered completely outpaces the liver's ability to clear it out. It literally just runs out of space. So, what happens? The fat begins to deposit directly inside the liver cells themselves. Grasping this basic mechanism, this idea of a totally overworked, overwhelmed organ, is absolutely crucial for everything else we're going to discuss today.
Moving right along to Section 2, drivers of fat accumulation.
So the crucial point we need to pull from the source material is that the absolute central driver of this whole process is insulin resistance. Here's how it works. When your cells become less responsive to insulin, your body kind of panics, right? It just produces more of it, trying to force that signal through. But here's where it gets super problematic for our factory. Those high insulin levels, they act like a massive blaring siren, telling the liver to store fat. And at the exact same time, that same high insulin actively blocks fat breakdown. So you're left with this perfect storm. The liver is literally being commanded to store more fat while simultaneously being told, hey, don't burn the fat you already have.
Now, it's pretty fascinating to see how everyday lifestyle triggers fuel that underlying insulin resistance we just talked about. It really starts with excess body weight, and specifically abdominal obesity. That actually increases the direct flow of fatty acids straight from your visceral fat right into your liver. Then, of course, there's diet. Frequent consumption of refined carbs and sugars, I'm talking white rice, baked goods, sugary drinks, anything with high fructose. These just completely overload the system and ramp up fat synthesis like crazy. Add to that a sedentary lifestyle, and look, we all love a good couch marathon, I get it, but when your physical activity is low, your muscles take up way less glucose. That forcefully shifts all that metabolic load straight onto your liver. Oh, and finally, while this is a metabolic issue at its core, even moderate alcohol use can severely aggravate that fat deposition if someone already has metabolic fatty liver.
All right, transitioning to Section 3, medical and genetic risks.
So beyond our everyday lifestyle choices, clinical practice tells us to watch out for a few hidden medical links. First up is dyslipidemia. That's high triglycerides and low HDL cholesterol. This usually tags right along with the insulin resistance we just discussed. We also see things like hormonal imbalances, PCOS in women, for example, and poor glucose control in diabetes playing a massive role here. Even having a sluggish thyroid that slows down your overall metabolism or taking certain medications like steroids or tamoxifen, these can independently force your liver to start stockpiling fat.
And this brilliantly illustrates the genetic factor. Because listen, this is not strictly a condition of visible obesity. Genetics and ethnicity play a huge, huge role. Certain genetic variants increase susceptibility drastically. For instance, South Asian populations are known to develop metabolic disease, including fatty liver, at a significantly lower body mass index. So the big takeaway? That liver factory can become completely overwhelmed even if, on the outside, the person doesn't appear to be carrying much excess weight.
Which brings us to Section 4, detecting the silent condition.
Let's move to our diagnostic toolkit and see how all this builds into actual clinical practice. If it's happening quietly inside the factory, how do doctors actually uncover it? Well, routine practice generally relies on 2 primary tools, the ultrasound and the fibroscan. Think of the ultrasound as your scout. It's almost always the first screening test performed. It works by detecting changes in the liver's brightness, which is caused by all that fat accumulation. It's widely available, it's affordable, and it's totally non-invasive. But it does have limitations.
It's a bit subjective depending on who's reading it, its sensitivity definitely drops in the early stages, and it absolutely cannot quantify liver stiffness. That's where the specialist comes in, the fibroscan, or transient elastography. This specialized test measures two very specific things: liver stiffness, which reflects scarring or fibrosis, and the controlled attenuation parameter, which is a fancy way of saying it measures the exact degree of fat. The massive advantage here is precision. It gives doctors actual numerical values, it differentiates simple fat from early scarring, and it's repeatable so progress can be monitored accurately. The trade-off? It costs a bit more, you usually have to go to a specialized center, and it can be tricky to read if a patient has severe obesity or fluid in the abdomen.
So, practically speaking, the clinical decision-making process generally looks like this. Step 1, you start with an ultrasound to detect those initial fatty changes. Like we said, it's a great starting point. Step 2, if that ultrasound reports a fatty liver or if the patient has known risk factors, obesity, PCOS, diabetes, abnormal liver enzymes, then you add the fibroscan. This 1-2 punch provides a really complete, quantified picture to accurately guide treatment and follow-up.
And now, for the best part, Section 5, the path to reversal.
While fatty liver has emerged as an incredibly common silent condition, often people just discover it incidentally during a routine ultrasound for something else entirely, it deserves our immediate, early attention. Why? Well, because of this exact quote right from our source material. The liver responds remarkably well to timely correction. I love that. Even a really modest weight reduction improves liver fat significantly. By understanding the stages, recognizing that core issue of insulin resistance, and employing structured treatments, long-term complications can totally be prevented. The factory can be cleared out. The damage is actually reversible.
We've explored how everyday triggers, hidden medical conditions, and even our own genetics can quietly overwhelm our liver. But we also know that with early detection through tools like ultrasounds and fibroscans, we can map out a really precise path to recovery. So I want to leave you with this question to think about. Now that you know the hidden drivers, what steps will you take to help your overworked factory recover? Thank you so much for joining me for this explainer. Keep asking great questions, and I'll see you next time.